Morning. Thanks to Laura and the SBC for inviting me to present on this topic. I'm going to focus my comments to metastatic spine tumor surgery, since that's what the overwhelming majority of tumor cases that spine surgeons in practice will face. And when thinking about metastatic spine disease, it's really important to think about this as a multidisciplinary disease. Surgery rarely adds to increased survival alone. And the benefit of surgery is really from the gain that comes next, and that's allowing patients to get on systemic and radiation therapy in a timely manner. And so really it's about surgery produces better function, which makes them candidates for radiation systemic therapy, which can ultimately improve survival. If you look at overall sort of data on survival after surgery for metastatic spine disease, what we see from the NSQIP is basically 30-day severe morbidity and mortality rates up to 19%. So these patients are obviously not well and are at high risk for complications. These are some of the risk factors that increase those risks, as you might expect. What's very interesting is the data is more and more showing that age does not seem to be a predictive factor for mortality or 90-day outcomes, although you do get an increase in medical complications. So we've sort of learned over time that age by itself is less and less of a predictive factor for poor outcomes after metastatic spine surgery. Similarly, when you look at length of stay from these surgeries, and obviously the amount of time these patients spend in the hospital is often to their detriment. These are the various characteristics and risk factors for prolonged length of stay, as you might imagine. And some of the ones to pay attention to are really preoperative anemia and pre-op hypoalbuminemia and nutritional deficits, which we'll mention in a moment. Really, ultimately, almost in any surgery, right, patient selection is everything. And certainly with regard to survival in these patients, patient selection is crucial because the biology and systemic status of the patients really dominate overall survival. Performance status repeatedly proves to be a predictor of survival. Their ambulatory and neurological status, as well as the primary tumor site. But what we've learned more and more, and what I've tried to introduce into this talk is really the most recent literature in the last couple of years. And we found that inflammatory nutritional markers play a huge role in predicting survival. And we found that patients who have nutritional deficiencies are at very high risk for morbidity and mortality. Also, the systemic therapy status really dictates chances of survival. For example, in non-small cell lung cancer metastasis, we find that patients that are candidates for postoperative targeted or immunotherapy can have median overall survival rates of 28 months versus those that are relegated to conventional chemotherapy of 13 months. And largely that's a reflection of the fact that they've failed some of those more targeted therapies in the past and that their disease is more aggressive. So when we think about approaching patients with metastatic spine disease and surgery, we all are familiar with various structured clinical frameworks. I think many of us think of this in terms of NOMS, most of which everyone knows. But what the emphasis is here today when we're talking about survival is the systemic piece. What's the systemic burden disease? What's their treatment history? What's their performance status, and what's their inflammatory and nutritional status? Because those will very often dictate what's going to happen in the postoperative period with regard to morbidity and mortality. Furthermore, complication avoidance at the time of surgery is basically equivalent to survival, right? And this comes into two factors. One is how that patient's coming to you. Are they referred to in a timely manner, or are they coming in an unplanned way through the emergency department? And what we've learned from this is planned versus unplanned surgery has a direct effect on outcomes. So patients with unplanned surgery for their metastatic spine disease have much higher rates of morbidity, mortality, and length of stay. And then on the flip side, once you're done with the surgery, perioperative adverse events similarly severely increase mortality, length of stay, and have poor neurologic and health-related quality of life outcomes. So the way you conduct your surgery is really crucial to the outcomes of these patients, not just from the surgery, but from their survival. We all know that wound issues delay systemic therapy. And so really one of the biggest emphasis, I think, to take away from all of this when you think about patient survival from surgery is really minimizing the surgical morbidity, because that's what gets patients on to their systemic treatment sooner. And so we sort of looked at this in a consensus manner with the AO Spine Knowledge for the Tumor Group. And our review of the literature was sort of looking at how do we minimize the surgical footprint in surgery for these patients. And essentially what we came out of this were some basic evidence-based recommendations, most of which are not surprising, but nevertheless saying that we recommend surgery for metastatic spine patients that are appropriate for surgery based on a lot of those systemic factors we talked about earlier. That integrating SBRT into the post-op radiation paradigm is crucial for moving these patients through their treatment and minimizing complications, utilizing MIS surgical techniques whenever possible, and implementing post-op ERAS protocols. And I'll say something about each of these briefly, but just for the ERAS, just to say that we already have data on this, that ERAS protocols post-op for patients with metastatic spine disease show decreased length of stay, time to ambulation, and decreased opioid use, which is often critical in these patients. So very briefly, these three other topics in terms of surgery. separation surgery we're all familiar with. It's become the workhorse. Has to be done in the right setting. So the goal, again, decompression, stabilization, and creating a safe corridor for high-dose post-op SBRT. The goals are no longer gross total resection or aggressive surgery, because SBRT can typically handle the residual disease with local control rates of up to 90% at 1 year. This obviously is predicated upon the fact that your radiation oncologist is willing to do SBRT in that particular patient that you're operating on. If this is not oligometastatic, their performance status is poor, they're not likely to be good candidates for SBRT, and knowing that ahead of time may dictate the type of surgery you perform or even whether you perform surgery. And in terms of SBRT, really that's become synonymous with local control, as I mentioned. It is particularly in radio-resistant tumors, as you're all familiar, and it's also dominant to conventional radiotherapy for pain. Again, coordination with your radiation oncology team is critical, involving pre-op, not post-op, when possible, because the most common failure also is in the epidural space. So if your separation surgery is not adequate or they're not able to do SBRT, you want to make sure you clear enough space around that cord. And finally, time to radiation matters. It really does. All of us seen patients have surgery for metastatic problem, delayed treatment for radiation, and there's already a recurrence within 4 to 6 weeks. So that's why this kind of a time frame makes the most sense of getting surgery, get them into recovery with ERAS and early rehab, get them to SBRT as soon as 2 weeks, and then get them to their systemic treatments. And then the last topic that we brought up in this review was the minimally invasive techniques. And when possible, when there's equipoise for the surgery, that you could do it either minimally invasive or open or some hybrid, the systematic reviews and meta-analyses have shown time and time again that minimally invasive techniques dominate on all of these perioperative parameters: blood loss, transfusions, complications, and most importantly, time to adjuvant RT. Last thing I'll say about surgery and thinking about keeping your patient's therapy ready, as you might say, is thinking about blood loss, because what's been proven in these patients is blood loss directly impairs post-op recovery. It's correlated with increased complications, length of stay, and even worse neurological outcomes, likely from hypotension. And so we liberally use embolization in the hypervascular tumors, and I think it should be specifically used for those, not for all tumors. And what that's shown is that preoperative embolization decreases blood loss, transfusions, operative time, length of stay, and has a trend even towards overall survival because of the downstream effects. And really, again, the aim, avoid delays to radiation and chemotherapy post-op. And then finally, an adjunct to this is what we've now learned is, despite the theoretical hypercoagulable state in these patients, we now have enough data, I think, to say that tranexamic acid in these patients is safe and effective and can be used during these surgeries to reduce blood loss. The last comment on emerging innovations that can affect survival. Advanced radiation platforms, including particle therapy, adaptive LINAC, real-time tracking, all these are designed around providing better dose of radiation to the tumors, so to prevent local recurrence. Navigation robotics firmly entrenched in spine surgery, but obviously have a role in these patients to reduce complications with instrumentation and enabling MIS techniques for more surgeons. But what's interesting, if you kind of look at survey data, not that recent, but for minimally invasive adoption in metastatic spine disease, it's only about 10% adoption. Cobra 5 instrumentation we're all familiar with and can improve SBRT planning. We're really getting now into molecular profiling and liquid biopsy. We find that for patients' primary tumors, and look at their molecular profile, by the time they've metastasized their spine, it's often got a completely different molecular profile. So when we're taking these tumors out of the spine, really important to send all that for molecular markers, work with your oncologist, because it completely can change their treatment. And then finally, we've heard a lot about AI-driven decision support in other diseases, but certainly has a role here. So take-home messages, basically survival is systemic. All right, so surgery enables, but does not guarantee increased overall survival. So it's really important to engage your multidisciplinary partners early on. The right there is sort of a staging system for non-spine surgeons to think about when to refer to your spine surgeon based on the acuity of their metastatic disease. As we mentioned, separation surgery and SBRT, when possible, is the metastatic standard of care. And complications cost survival by delaying time to therapy. So perioperative optimization is crucial with nutrition, ERAS, embolization, MIS, plastic surgery for wound closure, and early rehab. And this has sort of led to thinking about, with the AO group, the optimal surgical composite outcome in metastatic spine disease, really defined by complications, performance status, and neurological function afterward. And that's really should be our goal when we're thinking about surgery on these patients. Thanks very much.